Get started.
Hi, good afternoon. My name is Kaylee Clinton.
Hi,
What's your name?
Patty Smith.
Hey, Miss Patty Smith. So I am a student doctor here at UNC, and we're so glad that you came in today. We're just going to start with the basic, what brings you in, and kind of what has been going on.
Well, I'm just really concerned about what's been going on with me. And so it's just kind of gotten to a point where I just need to get some input on it.
Okay. Well, I really hope that we can do something to make it all better. You say what's been going on. Can you describe what's been happening?
Yeah, so I just call it spells. I've just been having these spells and, well, my husband's really, concerned and worried. So he's the one who really wanted me to come in today.
Well, I'm glad that you have someone that really cares about you. These spells that you're calling them, what happens? Do you not remember? Do you get blank? What's happening in these
Both
spells?
of those things.
Okay.
So I have to kind of go on what he tells me because I don't remember what happens
Yes, ma'am.
afterwards. And it's only for like a minute or two, but he says I kind of go blank, like you said, and I just, he says kind of make movements and stuff sometimes. And, of course, I don't remember. He just thinks maybe I lose consciousness, but I'm not like asleep or anything.
Okay. So these movements, is it the same movement? Does he say anything about them?
Well, I know my jaw sometimes, and I do recognize that. I have to, it like will jerk a little bit, but it's different every time I think.
Okay. Okay. That's good to know. Thank you. Do these happen at a specific place every time?
No.
No?
Just random.
Is there any kind of, like, after you do activities, you notice them happening more, or a specific time of day, like right when you wake up, things of that nature?
Just random.
Okay. And how long have these been going on?
The first one was, I'd say maybe a month ago,
Okay.
maybe
How many times has it happened over the past month?
3 times so far.
Okay. So 3 times in the past month. Before your first one, were you sick? Did you have any illnesses, viral, anything of that nature? Do seizures run in your family or any other type of neurological?
Well, so my mom told me, like a long time ago when I was really little, like 3, that I would have febrile seizures.
Okay.
But, she just told me that a long time ago, and I don't really know much about that.
That's okay. Were you ever seen by a neurologist, or did she ever take you to the hospital when you had these seizures?
I don't think so.
Okay. Thank you, that's really helpful. So you said your husband's noticed these and they're all throughout the day, or there's a specific time?
There's been 3, but I really don't even remember the time on those.
Okay. That's all right. Well, I'm gonna let another doctor review this.
Before we do all systems, we can finish the question for us.
Good morning. My name is Hannah Craft. I'm a student doctor working with UNC. Nice to meet you. Thanks for coming to see us. What's your name again?
Patty Smith.
So you want me to call you Patty or? Okay, yeah. Okay, so I kind of heard what you told Kaylee. So I just have a few follow-up questions for you. Just tell me to the best of your remembrance. So how did you feel like coming out of do you remember the spells, and how do you feel like when you come out of them?
Well, every time I have a headache afterwards. Not very long, but I do know that, but I don't remember anything. The only thing, I remember what happens before. Sometimes I get this feeling in my stomach.
Before it starts?
Yeah, and I know it's coming, and just this weird feeling.
Like, is it called it?
No, it just kind of was.
Did it hurt afterwards? No pain before it? Did it hurt anywhere? Have you ever been injured in one of these events?
No, but I am worried about driving a lot, because I do drive a lot.
Okay, so tell me about your family. So tell me about your family dynamic a little bit. Are you
Like
married?
what?
Are you
I am
married?
married.
You have children?
I have a daughter.
Alright, did you have any like spills during pregnancy or anything like that? So this is all just kind of recent.
Yes,
Okay.
since the last month.
Has any change like in your diet, in your job dynamic, anything like that? Okay. I'm gonna step out and I'm letting another student doctor come in and follow up with any questions he may have. Thank you so much for talking with me.
Yes.
Hey, my name's Wesley Davis. Will you tell me your name one more time?
Patty Swift.
Miss Swift, thank you. I think questions that have been asked so far have been like great. I honestly don't, like I've been thinking, I don't know what else I should ask. What would you guys recommend at this point?
Definitely basic things like alcohol, drugs, heavy occupation, things that might cause them to be things about how to make your head injury, family history, all that kind of stuff. And I usually ask them, I don't think we're gonna have the answer here, but this is important. Do you guys remember I told you cell phone video recordings? So this is the time to ask the patient, does your husband ever record one of these spells? Can we see what they look like?
Miss Swift, so we talked about like, as far as any of your family members, do you know of them having fanning spells or spells similar to what you might have?
Not that I know of.
Are you on any current medications?
I'm sorry.
Are you on any current medications? I think, you went through a period where you might have had one of your spells. That's why we were talking right here. How did you feel?
It's just scary, cause I don't know when it's gonna happen.
Okay. Did you have that anxious feeling before that moment?
I think so, yeah.
Okay. I'm sorry, is there anything I can do for you right now in this moment? We were talking about medications. Did you say you are on any certain medications right now?
No, yeah.
Okay. Have you had any like prior surgeries, especially with your nervous system, your brain, anything like that? Okay. Okay. So I know your husband is really concerned about you having these spells. Has he described to you kind of what happened when you go through it, or maybe has a video recorded on his cell phone or something like that?
No, it's only happened 3 times, and, I don't, he's not aware of it, he just notices it, and it's only for a couple of minutes, so I don't think he's got a video, or he would probably show me.
Okay.
But the only thing he tells me is that I kinda go blank, and, I jerk a little bit,
Okay.
and, I don't remember, I can say I don't remember anything like during, like what happened.
Okay. Would you talk to me about like your alcohol use, alcohol, tobacco use?
Yeah, I don't drink, I don't smoke.
That's great. That's great. What do you do for work?
So I am a math teacher at a middle school at NRA.
Okay.
That's why I'm concerned I live in Clinton and I have to
Right,
drive.
you have to drive. Right. So yeah, I do understand how it's concerning.
Did you play any sports growing up?
I did a little bit of track.
Have you ever had any, like head trauma clawing at your head, anything of that nature?
No.
I think we should definitely set you up for some, like, evaluation, maybe some observations, maybe have like a head CT, just to be safe, or an MRI, maybe an EEG, just so we can see, maybe we can capture one of these spells and look at it, on our computers and kind of see what areas of the brain may be involved, and maybe we can even see, like, you have these, post-seizure kind of feelings of anxiety. Maybe we could capture one of those and do something for you to help. Maybe we could, we have several treatment options available that could possibly help you. So there's definitely hope, and so I think at this point we will need to do some further evaluation and testing to help you.
Okay,
Yes, ma'am.
thank you.
Thank you.
Okay, somebody needs to ask some personal and family medical history. Did they get that? Oh, I'm sorry.
No reported family history.
Okay.
No reported trauma or head injury. No reported medications. No drinking or smoking. Can
Illness
we-
history.
Can we kind of discuss as a class what we observed?
Abs-
Any assessment, what we observed during that spell?
Of course.
For the, sorry, I cut you off, guys. For the past medical history, we asked for specific questions, but sometimes these patients don't really remember things that may have happened when they were very young, like during birth or in infancy or in very early childhood. So you may ask them, have you ever been brought into a hospital for any reason when you were a child, or did your parents ever tell you had spells or seizures? So those are the two questions that I would ask, just to make sure.
Do we need to ask her? She already said she wasn't brought to the hospital and had people.
Oh, she got that, okay, perfect, on
I
that
was
session,
supposed to
yeah.
do like sexual history and stuff, yeah, I didn't,
Mhm.
have something like that.
Yeah. No, this is not an emergency situation, so you want to go ahead and flesh out your history, even if you don't necessarily think that it's going to contribute much. You want to cover your bases, because you'd be surprised. You know, I mean, for example, people who are HIV positive can have CNS components to the disease that are usually, especially now with modern medications, are kept, to a minimum. But, if she'd been diagnosed, 15 years ago, there could be some pre-existing damage. So you want to know, you want to go back and get that kind of information. That's not that's not my go-to here. This is just as an example of things that can have happened that,
Absolutely. I mean, just a couple of weeks ago, we had a seizure patient in clinic who was never, ever, ever tested for syphilis or HIV, and good enough, they're syphilis positive, and good enough, they have CNS syphilis. So it happens. So that's why it's extremely important to get a good history. Yeah.
especially now. I mean, I don't know whether to be proud or disappointed that Mississippi is either number 1 or number 2 in syphilis in the country.
How did you go about, like, knowing to test them for that? Because I can't imagine that y'all run syphilis screens on.
Oh, we do.
Everybody.
We almost every time we do in neurology.
Yeah.
So I don't want to diverge too much, but yeah, so I don't want to diverge from the case too much, but not just seizures, but neuropathy, cognitive problems. Syphilis can mimic anything. So, and some patients will tell you that there is no way they have it, that they have been married for a very long time, but you always tell them, we screen all of our patients because it's a very treatable common disease, and if we figure out what is causing your problems, we can treat it very easily. And then they say, okay, go ahead and screen me then, and then unfortunately most of them will come back positive.
Mrs. Swift, I had a few follow-up questions for you.
Okay.
Will you tell me, so you're married, will you tell me about your sexual history with your husband?
Well,
been screened or treated for any type of sexually transmitted disease? Okay, okay. What about your husband that you know of?
Not since I've known him, so maybe before I haven't.
Okay, okay. Do you, Lisa,
Please. We're gonna just go here together.
Small.
Okay, okay. So, we have, so about our sexual wisdom.
okay,
Okay, I'll go after you. You go.
Okay, so we're talking about your sexual wisdom, and, you know, it's something we ask everybody, so no judgment here, so just like be as transparent as possible. So have you ever been positive for any STD that you know of?
I've never been tested, but my parents.
Okay, have you noticed like any vaginal discharge or pain during sex or anything like that? And what about when you were pregnant? How did the pregnancy go?
I don't remember having any complications.
And what about right now? Are you pregnant right now?
I don't think so.
Okay, are you having normal menses and a long menstruation?
Yes.
Okay, and when was your last period?
Last month.
Okay, do you remember the date?
Tuesday in the middle of the month.
Okay. So are you expecting like a period soon?
I hope so.
Yes. Hey, Miss Swift, since I witnessed one of your spells right now, I just wanna go over kind of head to toe, various symptoms that you could be feeling, and you can just simply answer yes or no. We're gonna go all throughout the body, and this could really help us kind of pinpoint, what may be going on. So do you have a headache right now?
Not at the moment, but I did right after the.
How long did that headache last, would you say?
Maybe a couple minutes.
Do you feel sleepy or groggy?
No.
Have you noticed any changes in your vision? Blurry, seeing multiple of me, anything like that? No, okay. What about hearing? Did you have any ringing in your ears? Anything of that nature? Okay. Are you having like any pain anywhere? Any joints, any muscles? I know you keep moving your jaw. Does it hurt? Are you like just moving it because you want to, or is it not really something that you have control of?
I don't. I just
Do you have any trouble chewing? Have you ever had anything like been diagnosed with like TMJ, like lockjaw, or anything of that nature? No. Have you had trouble swallowing? Anything with like sinus infections or trouble breathing? Do you feel like you get short of breath doing everyday tasks?
No. I would walk every day.
Okay. You've mentioned that having these spells is kind of scary for you. I completely understand that. Has it prevented you from doing anything that you enjoy doing?
No, but I'm getting scared as it keeps happening, especially when I'm driving.
Okay. I know you mentioned you've had 3 in the past, and then this 4th one that we just saw. When was your last one?
I think the first of last week.
Okay. And then do you remember when, I know you said the first one was a month ago, do you remember when the second one was, just to see if they've been getting more frequent, or?
It was closer to this last one, but
It was.
yeah.
Okay, thank you. And then back to our symptoms, you haven't had any muscle weakness after? No? Okay, we're gonna check all of that here later, to make sure. Have you had any change in appetite, any GI, have you been going to the bathroom regularly?
No, I just that sensation in my stomach before.
Okay. Can you describe that sensation in your stomach? Like, is it just dull pain everywhere? Is it?
It's not really a pain, it's like just this sensation, almost like anxiety, but not. It just,
And how long does that last typically?
just for like a second or two, I can feel it, and then it's coming, and then.
I know this is a very personal question, but do you lose any sort of, like, do you urinate when you have these? Any uncontrolled You were sitting down when this one happened. Have they ever occurred standing, or you don't fall or anything like that?
I haven't, it's been when I was sitting there.
Okay. Do you have you previously been diagnosed with any sort of anxiety or depression, anything of that nature? Do you have trouble sleeping? Do you sleep well? What is your sleep schedule like?
I do, regularly, like 6 to 7 hours.
Okay, that's good. That's good. Do you have a history of any autoimmune things?
No.
No. Okay.
Is it regular?
It doesn't hurt, right? Sometimes I don't know when it does it.
How long does that twitching last typically after?
That's the only thing that I remember or do, because it happens even without a spell.
And just some basic medical history. Do you have hypertension or high blood pressure? Have you ever been diagnosed with either of those, or concern for like your basic labs, like high cholesterol, things of that? Sure.
I don't remember being tested.
Okay. Do your parents, do you remember either of them having, it's very common in Mississippi, but having hypertension or diabetes, anything of that, high cholesterol?
If they do, I don't know about it. They're pretty healthy for their age.
They are, okay, that's great, that's good to hear. Does somebody else want to take over and do like a physical strength?
Do you take anything for the headaches? Like, how do you alleviate the headaches? Or do you?
After the spell,
Mhm.
they go away.
On their own?
Mhm.
Okay. And what about, do you take anything for them while you're pushing, or just kind of always kind of there?
It's just there.
By the way, remember something about family history. It goes up, down, and side to side. So, so you want to ask, have your brothers and sisters had any problems? You said you have a child. Has your child had any problems that you know about? Okay? Chances are pretty, most of the stuff is vertical, but you always want to make sure you're covering your bases.
Do you have any siblings?
I do. I have 2 older sisters.
Okay, have they ever experienced any types of spells like this that you know of?
I don't think so.
Do they have any past medical diagnoses?
No, they're pretty healthy too.
Okay. Have they ever been to the hospital that you know of?
I don't think so.
And then your child, your daughter, have you ever had to take her to the hospital for febrile seizures like you mentioned that you've had, or anything of that nature?
No.
No. She's healthy too?
She's healthy too.
Oh God, that's so good.
I do have a cousin though that
You do?
has multiple sclerosis.
Okay. Yeah, first cousin? Okay. Is that the only person, is her, that has been in your family? Her parents don't have it, or anything? Exam.
Have you been out of the country recently?
So I'm writing things down here, because you guys did really good with the radio systems, getting sleep history, everything was perfect. And our patient brought up something super important that we always legally have to ask to anyone who's having spells of altered mentation. Doesn't matter if it's syncope or seizures or dementia. She said she's feeling scared because she's driving. Would you be worried about someone on the highway who's having these spells? All right, so we have our seizure precautions, right? Same thing applies. Do we know what occupation she is doing?
Yeah, she's a teacher at MRI.
Perfect. So as long as that occupation doesn't involve climbing up ladders of 6 feet high, or painting a commercial, building, or just working on a rooftop, which unfortunately, a lot of our Mississippi population, because it's a very, it doesn't really require a lot of education, and it does have pretty good income. Most of our seizure patients do work on rooftops. So this is the time we legally tell them and advise them, until we figure out what's going on, and unless you are spell-free, we advise you, per the Mississippi laws, not to drive for 6 months. And there's one more thing that we have to mention in history. would you be worried about this patient bathing in a bathtub full of water alone? Yeah, they can't drown, right? Yep. So this is the time that you also ask them and you will now counsel them about it. Granted, you can do it at the end of the conversation, at the end of your physical exam too. But you will notice in clinic, it doesn't really follow a perfect format and things come more naturally. So this would be the time that I would kind of bring that up. I do want to tell you guys, because all of you try to figure out what that stomach sensation is. They can never ever describe it. It's always, it's weird. Just feels weird. I don't know, something. Or they say that there's something comes that is odd, it's weird, and they can't even describe where. At least we have stomach here. So there could be something weird. Go ahead.
What do you do for patients that live alone?
That live alone,
Like, what do you advise them to do?
we take them to epilepsy monitoring unit to figure out what's actually going on. And if they are having electrographic seizures or frequent seizures, then we advise them to either live with a family member or we just try treating them in the epilepsy monitoring unit until we can figure out what's going on. And then, social work consult is a great thing. I'm gonna go ahead and say a couple more things, and so our patient is, you guys noticed it and you asked questions about it. There's some twitching and fumbling, and I do not want you to think, let me rephrase this. In a patient who has automatisms, we just discussed this like an hour ago, right? Kicking movements, necklace, or chewing movements. Would you expect them to keep talking to you and remember that they're talking to you right now? If it's a seizure. Not really. So remember, most of the fumbling, picking, and mouth automatisms, chewing are temporal lobe seizures. It's right next to your hippocampus. They usually are not aware that they're doing that. So this presentation right now, playing with the necklace, in clinic, I would call this just a nervous tick, to be honest with you. I would not call this a focal seizure. So I do not want you to think that these are seizures if you do see this in real life in clinic. Patients are talking to you and their movements are pretty variable in frequency, amplitude, they're distractible, it stops, it comes again. Not a seizure. This is not a seizure. Okay? But I think in our scenario, we were supposed to have some of them like staring off and doing that. So think about that when you're doing the exam going forward.
Is it related to the seizure though, but just not the actual seizure? Because I noticed her fumbling with her necklace, like that's something I do when I'm nervous.
Yeah,
And
it's not
doctors'
supposed to be
offices
related.
aren't exactly the most comforting place.
You're exactly right, and these are not supposed to be related to seizures. If you see
Okay.
exactly as in real life, what is supposed to be seizures? You had that episode where there was some staring off. If you have any jerking or any fumbling movements around the staring off. Now this is another part of the exam. I don't want to ruin too much for you guys, but please try to do this. If she has another spell, we give the patient some words. We say they're staring off and they're not really talking to you, right? You don't just stare at them and just look. You tell them, remember the words blue butterfly, blue butterfly. You said it a couple times, and after they come back, you're like, do you remember what I just told you? Do you remember those words? If it's psychogenic, they usually go like, blue caterpillar. They say something very similar, and you know they weren't completely out. So you assess for their awareness during the spell, and that's a part of your exam. You don't have to wait for your exam until you're done with history. Your exam starts as soon as the patient walks into the room,
Okay.
right?
Would you ever like tap them on the shoulder and be like, Mr.
Absolutely.
Davis, is that okay, or is it like do not touch them?
You can definitely tap them or touch them. If they're closing their eyes or doing something, you could attempt opening their eyelids and see. Remember the psychogenic signs that we talked about? If they're resisting it or moving away from you, then you know there's a purposeful movement. So you could do that in clinic. That's completely fine. But I would probably just start saying things so that you can assess if they're aware during the episode or not. All right.
Is there anything else that you need to assess for during the episode, or just like awareness? That's our main thing.
If it was just a focal normal episode like that, just that. And when you guys are rotating, you might actually find it useful. We do that sometimes. You can record the video and put it on Epic near charts too. That's sometimes helpful. That's it.
Would you, like, after that episode like that, would you ever do an EEG, like, right after or something? Or do you usually just kind of?
Wish. So, it's time we bring up the Z word. So we have this amazing rapid EEG device. It's literally like a hat, and you kind of like screw it onto the patient's heads, and when they're having a spell, if the hat is on, that's a portable EEG device. It's called a fast EEG device. So you could use that, and that is available in the emergency room and in the ICU, not in the clinic. This is a pre-clinical diagnosis anyway, so you wouldn't really need that. But a regular EEG that is conventional that you definitely need for a diagnosis of seizures is with the little sticky leads that have the cords, and you have to get them into the hospital.
So those are, they're only hospital, you cannot do EEG.
Just like you can get a CT for somebody you see in clinic, you see them in clinic, you order a CT, they go to the hospital, they get a CT, same thing with EEG.
It takes about 30 minutes to prep their skulls, so you're not gonna be able to get it in the clinic. Some pediatric clinics at all clinics usually don't.
Can you do it outpatient, or is it like if you're getting an EEG, they go to
Outpatient.
check in?
It's, no, it's definitely an outpatient setting, yep. Yep. Yep.
So these patients, like, you can send them home, even though you know something's.
You can't
Can
send them
send them
home
by
with,
Walgreens, off the
there
way
you go,
home to
with
pick
the
up
medication.
And someone else driving.
Exactly, like call someone to
So
drive you home.
mentioned there's like a ton of, sorry, I have a lot of questions.
Go ahead.
You mentioned there's 30 different seizure medications. Are they, like, do you have to know, like, oh, this is this type of seizure, so therefore you put them on this medicine? In which case, how do you just be like, go get your EEG, take this med, before you have the results?
Great question. So remember the type of seizures, the two big categories, focal and generalized, right? There are two big categories of seizure medications too. Narrow spectrum and broad spectrum.
Okay.
For focal seizures, both broad spectrum and narrow spectrum work. For generalized seizures, like for the absence seizures that we were talking about with 3 Hz spike wave discharges, or myoclonic epilepsy that's generalized, if you give them a narrow spectrum anti-seizure medication, and do you guys remember which ones those are? Phenytoin, carbamazepine, oxcarbazepine, all the old ones, mostly all ones that we use on narrow spectrum, that can induce status epilepticus. You will make the patient worse and they will end up in the ICU. So for them, we give broad spectrum, levetiracetam, Keppra, valproic acid. Not in a female likely because it has a lot of side effects. But broad spectrum and narrow spectrum is important for that reason. For her, and some of the medications, this is also important. Side effect profile is important, but if somebody's having that many seizures all the time, you probably wanna pick something that's gonna get into their system pretty fast, and you don't wanna give, for example, lamotrigine, which is a great medication, but it takes about like 2 months to build up in your system. You don't want that, you want something a little faster. So Keppra would work, lacosamide, anything would work.
So if she wouldn't have had this spell in front of us, would you just assume broad, that way it covers all of them?
Absolutely, that's a great thought.
And they would still not need to like bathe by themselves or drive even though they're on the meds?
For 6 months until they're spell-free per the Mississippi law. Some states require 1 year. And
Okay.
if patients are non-compliant, even though state says 6 months, I tell them 1 year.
Okay. That way, makes sense. Yeah.
You just gotta, and anything, you just tell them, if you were to have a spell, you don't wanna harm yourself or others.
Chain smoking use. Campfire.
So anything
Ladder.
that could cause that. Yep. All right.
If the patient's like, I drove here by myself and they're like,
Uber,
I've
Call
got-
someone.
Uber.
But if they're like refusing, if they're like, no, they wanna
You
drive.
document the best you can.
Yeah.
And that happens.
Yeah.
You have non-compliant patients, people leave AMA, not everything was perfectly. You just document the best you can, that you consult the patient, you discuss the risks with them, and they had the capacity to decide on their own, and they refused, and that's it.
Okay. Yeah, okay.
Yeah,
Didn't know if you're supposed to like call the cops legally or something like that.
We're
No.
totally, there is a whole form and everything though that we can fill out and get licensed.
Okay.
Yeah, we're not DMV, so we
We
can't
aren't.
force them.
I had that question too. So yeah, I imagine you weren't cutting up licenses in the office, but.
We do not do that.
no.
Okay. Are we going to start clinically?
Absolutely.
Would you, like, do all the, my thought is to do a normal physical exam.
Okay.
With a neuro exam. Is that your thought as well?
So
Or,
realistically, why, okay, so let's talk about this. Normal physical exam, meaning listen to the heart, chest sounds kind of thing?
yes, and like tests, like does she have equal
Also-
muscles,
oh.
pulses, like can she
But
move
a
her?
full neurologic exam, that's what you're saying?
Like, that's what you would do for any patient with a physical exam? Like you're gonna check their muscle strength in each arm, like would you recommend doing
doing all of
I
that?
think I understood your question wrong, but yes,
Okay.
so what I understood was, would you do a general exam? Like, I don't
Yes,
really
plus
auscultate
neuro.
everything in
Uh-huh.
neurology, so not really. I don't
Okay.
really listen to the heart and the lung sounds and palpate the abdomen, that doesn't happen.
Okay.
So if I know that this patient is having a seizure and they're not coming to me for anything else, I'm a subspecialist. So what I do is I start with mental exam, right? So are they oriented? Are they alert? Are they awake? Orientation questions are important. I do a small recall thing, like I give them some words, and like, I'm gonna ask you them again in a little bit, like at the end of the exam, are you gonna be able to recall them? That tests for memory. You're thinking temporal lobe seizures, so that's a perfect test to do. Their language, they're able to talk to you, you document that they are, fluent and stuff like that. And then you go into your normal neuro exam, that you were mentioning. So definitely motor strength everywhere is very important, but for a patient that is coming with seizures, you don't have to do one by one, finger flexion, finger abduction, and carpal tunnel things, right? You don't have to go into that much detail. A gross upper extremity, lower extremity, proximal distal is fine, right? Facial symmetry, very important. So cranial nerves, you can get most of them by just looking at our patient and talking to her. You don't have to really go ahead and, do a lot of it separately. And then sensation, if it is just for seizures, you don't have to test for pinprick, vibration, proprioception separately. You wanna make sure that there's nothing focal, like, let's say the right parietal lobe tumor that's causing these seizures, right? So you wanna make sure that they don't have left-sided numbness at baseline or something like that.
Okay.
So I would you can do just pinprick and, just touch, and you would be done with it, right? You don't have to do a very, very detailed, is your toe going up, or is your toe going, do you guys remember the proprioception test? You don't have to do that here. You can be a little bit more general. That will save you time. And of course, you never, ever, 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 ever do a neuro exam without a reflex MR. So sometimes everything is stone cold normal and there is asymmetry in the reflexes. And that gives you the diagnosis. So look for symmetry, look for reflex if there's anything pathologic. That's it. It sounds like it's a lot, but the entire thing takes about 2 minutes.
Something tells me it's gonna take us a lot longer than 2 minutes.
Go ahead, take your
Right.
time.
So
Take your
number
time to do
one,
it.
she mentioned gross upper and lower extremities, so
Yes,
Yeah.
so yes.
I'll list it
Would you
then,
like
we
to-
can,
okay.
we can go down it
Well,
together.
we'll start with, can you tell me where you are? What state are we in?
Mississippi,
Okay, and what city is this?
this is Jackson,
Do you know what year it is?
2023.
And what is our president? Okay, can you give me a nice pretty smile? Fabulous. And then I'm gonna check your, motor, so what I'm gonna do is I'm gonna ask you to push against my hand, so push up. Okay, we're gonna do the same on this side. And now we're gonna do opposite, you'll push down against my hand, and then okay, and we're gonna do the same thing with your legs. So you'll push up against my hand, okay, and then on this side. And then, pull back. Yeah, thank you. Okay.
Did you notice anything?
I didn't. She's got the same strength, both sides. Real great, you're strong.
That's perfect. What you did is great, but I'm gonna do instant feedback just so it kind of
Please
sticks in
do.
everybody's minds. So if there is a little bit of weakness on, let's say the right side, and you're going like this, push against my hand. You're not really giving them the, full, time to resist against you, because you're already pushing on them.
Okay, so just start with like a.
So here's how I start. Put the hands up like you're holding a pizza box. Close your eyes. If there's a little bit of weakness, this is I think this is like the easiest way of doing it.
Okay.
If there's a little bit of weakness on the shoulder, they're gonna start pronating. We call that pronator drift. It starts drifting a little bit. It doesn't go like this, but it starts pronating like this. And it's just because this muscle works on supination, right? So if you see this, there's a little bit of weakness. You will not be able to get that if you're like, push against me, pull against me. That's not gonna give you that
Okay.
muscle weakness. So close the eyes. Is there pronator drift? If not, then let's go to Jordan. Okay. And then I go, squeeze my hand as tight as you can, pull me in, and push me away. That's the easiest thing you can do. Or you can go like this, don't let me push down, go like this, don't let me pull, extend the arms, don't let me push, don't let me push.
The other thing is
You
having
guys-
them like assume the position and like make the strength happen gives them mechanical advantage. So even older folks should be able to actually overcome you if are in the mechanical advantage if they're 5 out of 5.
Same thing with the legs. If I go like this, push against me, she won't be able to if she has a little bit of weakness, or if it's a little asymmetric. If I tell them, put the knee up as high as you can and don't let me push. 1, 2, 3. Put the other one up as high as you can, don't let me push. Kick it out, don't let me push it. Kick this one out, don't let me push it. So I give her the advantage of doing the full extent, and then I oppose it. Does it make sense? Okay, you guys wanna try it again?
Yes. Do you wanna try it?
I'll
Or do you
try
want me to? Okay,
So
go
do the
for it.
full motion, then oppose it, that's it.
Okay. Ms. Swift, I'd like to do a physical exam with you. Would you extend your arms as I'm doing here? Okay. All right. So. Oh yes. Now close your eyes.
Let me give you a bonus point. With this finger, touch the tip of your nose. Come back out. With the other one, touch the tip of your nose.
Perfect.
Now you also got the sensory and cerebellar part.
Yes. Okay. Okay. So I didn't see any drifting. So now I'm just gonna check your your muscle strength. So hold your arms out and don't let me bend your elbow. Okay. Good. Good. Okay. Now flex your arms like this and don't let me pull your arms out. Okay. Here. Okay. Feels good. All right. Hold your shoulders out kind of like a chicken wing, and don't let me push them down. Okay. Good. Good. All right. You can let your arms relax. So now, kick your knee out. Yeah, yes. Now don't let me push your leg out. Okay. I'll do the same with this one. Okay. All right. Now, okay.
Flex the knee, so that's hip
The knee
flexion.
up. If you pull your
Flex-
knee to your
Yeah,
chest.
pull your knee up, and don't let me pull it out. Just hold it there. Okay. Good. And same with this one. Good. Good. Okay. Relax.
So what, this one was hip flexion, right?
Right.
This is the.
That's okay.
There you go.
Okay, I didn't do that one. All right, flex your leg here for me. All right, and I'm gonna try to push it down and hold it right there. Okay, and same with this one. Okay, okay, good.
I have a question. When are you giving like words? Like at what point of the exam would you give them words?
The very beginning, the orientation
And
questions.
then like after so many minutes, you ask them to repeat those words. Do you have a go-to set of words?
I honestly, I really should.
Apple table penny is the MMSA brothers, right?
Which one?
Apple table penny.
Although there, I'll throw in the psychiatry side here. It's often good to have a word that is not a noun in there. So you might say, apple, penny, run, okay? And the only reason for that is that it takes away a clue in terms of remembering the words. The patient is not gonna notice that there is a clue embedded in that because all 3 words you used are nouns, but there is. And however, again, we're starting to get into the weeds a little bit, you know. When you're starting out, 3 nouns, just fine.
You have any 3 words?
Yeah,
Mine changes all the time depending on anything.
yeah.
So we did, we're gonna give her orientation words and general muscle strength is now when you would recommend doing reflexes and pinpoint. What is your logical, I know it doesn't have a flow and things are different.
That's okay.
What would you?
So I always think top to bottom, and I always visualize our doctor in if it's not template so that it kind of helps going through it. And once you do it 2-3 times, it flows. So mental status first, right? With mental status comes language and memory. And then think about the head. Now we have eyes. Are they able to see? Are their pupils equal? And then I look at their eye movements. I don't have to do an H test if I don't have time. They are following me around the room fine, so I know that their eyes are not disconjugate, right? Are their face symmetric? So you got the cranial nerves 3, 4, 6. You got the facial nerve now 7. Are they able to talk okay? So no dysarthria. It's going to give you kind of 9, 10, also 12 a little bit. And then for this exam for this presentation, we don't have to do sternocleidomastoid, you're fine. But again, top to bottom kind of makes you organized. And then,
Hearing intact voice, say it.
yep, they're able to hear you, they can, respond, that kind of
How much
gives
do
you.
you, of that do you do, like, actually do though? Because, like, I can do that on her, but I know she can hear me, I know she can respond, because we've been talking for 30 minutes.
I do it I almost always do it, and it never takes me more than 30 seconds. Do you want us to kind of, like, do that really quick and?
Yes,
Okay.
I'd love to
Yes,
see
please.
that.
It's very, do you want a quick, okay,
Sure.
I'll do a quick exam with you. So I usually just sit like at the eye level with the patient, just so we have the same visual field. So I'm just gonna go top to bottom again with the eyes. So if I had a pen light, which there is there, can you take your eyeglasses off for me? And I know that they're equal symmetric right now, so I do direct, consensual, look at my finger, follow my finger with your eyes only. There's no nystagmus. The eyes are moving completely symmetrically. We're good. Never ever forget the conjugate gaze. They go midline. On your teeth, puff your cheeks, close your eyes as tight as you can, open your eyes. Okay, so technically you would want to do one at a time, but sometimes I just look at my nose. How many fingers do you see on each side?
2, 1, 5, 1.
Okay, I'm gonna touch your face right now. My hands are a little cold, I'm sorry. Can you feel this and this the same?
Yes.
This and this are the same.
Yes.
Close your eyes. Can you hear this?
Yes.
It's the same on both sides. If they have a little bit of sensory or hearing loss, that they will be able to appreciate that. And then you can do, turn over that way, don't let me push you, turn it this way, don't let me push you. You're done, that's it. And then you do this, pull push, and then the sensory exam. And then the reflexes. It really, honestly, all of it does not take more than 2 minutes. But you just gotta do it like 2-3 times and it gets faster. Don't get scared. You guys can go ahead and do it if you want. Okay. Here, you have to- it's okay.
Okay, Miss Smith, thanks for letting us come and do stuff to you. Okay, so I'm gonna do a full like neurological exam, examining your cranial nerves, and just try to follow my directions.
Okay.
Okay, so first,
Technically, sometimes people say, don't blind them with the pen light, you can just go with the visual fields first and then do the pen light, because some people are sensitive and they see flashing lights everywhere after.
okay. Also, I'm gonna give you 3 words to remember. Apple, pennies, run, and after then, I'm gonna ask you to repeat those words.
Okay.
How many fingers am I holding up? 2? 1? 5?
If you can't see
It
it,
might
she
be my
can't
fault.
see
It
it.
might be my fault,
It's
right?
okay.
Okay. Now, okay, follow my finger and try not to move your head, just move your eyes.
That's the H and then inside. There you go, you got it. Perfect.
What I'm doing? Okay.
Hearing and sensation.
Oh, right here. You feel it? Feel it?
And now you're gonna close your eyes as tight as you can.
Okay,
Put your eyes as tight as you can. Smile. Puff your cheeks out.
remember the cranial nerve or trigeminal has 3 branches, so don't just touch one place on the cheeks. You wanna hit forehead, cheek, and down your chin.
Okay, do this.
They did the, external isolation too.
Try to show your shoulders up.
Perfect, that's it.
Good.
Thank you.
Okay. Now you did the muscle reflex.
It, can you demonstrate that as well, like the reflex exam?
Yes, oh, yes, of course. So, can you show me how you take a reflex? And I have hyperreflexia. Do you have hyperreflexia? Most people have hyperreflexia, so try to get my knee-jerk reflex, and I'll show you guys what you should and should not do.
Well, you could have what the patient had last week, which was, anticipatory hyperreflexia.
Oh, that happens.
The hammer hadn't even hit.
So I'm not gonna look at all.
Okay.
Let's see if you can, but I need to actually look at how you're holding the
Okay.
reflexes.
I don't know if I'm holding correctly.
That's
Just
okay,
tell me.
just do it.
Okay. This is my first time to ever do this.
We,
So,
we love it.
okay.
Get it.
You won't hurt me.
Okay.
I'm at tendon. The tendon.
Is that okay?
That is completely fine, and you actually did it fine. So sometimes I see you guys holding the
Very
reflexer
blessed.
like this. Like your finger is there and you're going like this, you're not gonna get anything. I have super bad hyperreflexia, but even I don't have any, well, I do a little bit. But this is not gonna give you anything. So you have to hold it from the very end, right? You've gotta get a good torque physics. So the more distance, the better. And now you're gonna give it a good swing. And you don't, for the knee reflexes, sometimes most of our patients have, can I get closer to you? So most of our patients, some of them, have, knee replacements, so you don't really have to go to the patella, but you can also, you have hyperreflexia too. But you can actually go a little bit over here, and it's the quadriceps, so you will see that the muscles are, contracting here as well. So, before we go down, let's start from the top then, let's do the arms first. So, starting with our patient, with the arms, do you wanna start with the biceps?
Yes, so is the biceps tendon right here? Is that what?
Yes, so biceps tendon is right here. Most of the time, you don't really have to really palpate it and get that exact great spot.
Okay.
You tell them to relax, and then, I really like it when their hands are kind of in a neutral position, cause then I see if the pattern is spreading or not. I see most of you guys putting the, finger over here and hitting your own finger, which you can do.
Yeah.
But you can also just do this, and you see it's spreading over there, so this is a good reflex pattern, so that's brachioradialis, and you have the biceps over here. And I can actually palpate it over here when I'm hitting you.
Okay.
Were you guys able to see the hands, fingers, flexing a little bit?
I don't think this side's always good.
Okay.
Do you guys wanna try it on each other, or our patient?
Somebody can try it.
Do you wanna try it on our patient, or do you want us to try it on you?
They tried on me. Hold on, let me get this. That's fine, so you can see. Do this arm, because we did the other arm. Alright.
Well,
If we-
let's
can we?
actually,
Okay.
let's do this arm, cause I have to stand over there.
Okay.
Alright,
Can everybody
relax
see?
your hand in
Okay.
a natural position. I'm gonna do here for brachioradialis, which is the
Yeah.
fingers, right?
And you look at the fingers when you're doing that.
I don't know if I'm doing it right, or
You
if
are.
it's just moving.
If you're not able to get it, it might
Okay.
sometimes help to just put your fingers over here, so that it kind of spreads it. You look somewhere else.
Over here, friend.
Oh,
Over there. So
There
when
you
you see
go.
it?
Okay, yes, okay, that was right, okay.
You got it.
Fabulous.
And then you can also do it over here,
Look,
which,
Francis,
you know,
don't
you
do
will
that.
see the biceps
Mhm.
here. Triceps, in real life, you usually don't really check unless it's a neuromuscular patient, so
Okay.
just go like that.
Okay.
Alright.
While we're
Try it
trying
out.
that,
Try it out.
does the previous history of muscular sclerosis, I'm assuming that has something to do, was that
Multiple
important?
sclerosis?
Sorry.
You're
It's
completely
really-
fine. So what is multiple sclerosis? Did you guys learn about it yet?
No, that's,
Not yet,
they,
next
they've
time?
got a couple of,
Absolutely.
Is that right?
You're so close, it's actually central nervous system.
Central, okay.
So if it's central nervous system and you're demyelinating some neurons in your brain, you actually do have increased risk of seizures too. So
So that's something you would check her for.
So,
Okay.
yeah, so I really don't think this is related, but you never say never, some multiple sclerosis patients have seizures. She doesn't have a history of multiple sclerosis. You guys will learn about that more.
Okay.
Our history doesn't really say that either, so I wouldn't be worried about that for her.
Mrs. Smith, is it okay if I do a reflex exam on you?
Sure.
Alright, if you would, just lay your forearms across your thighs, kind of in a neutral position, just relax, and maybe look at the wall over there. You wanna try?
yeah, there you go.
You
You
did
got it, first time.
Ready? Okay,
That's perfect.
okay. Alright, do we do up here as well? Is that?
It's
we need to?
You just
Here
did.
and
Okay.
here.
There you
Same
go.
thing, yeah.
Did you guys see it? It's a really nice trip. So that's pretty brisk, nice, 2+ reflexes.
Okay.
Yep, that's really
Great.
good.
Okay, so now you're moving the knee.
Okay, so, you were doing it right In the
You can, so
thigh here?
if you, in a regular patient, if they don't have a knee replacement or any knee complaints, go ahead and do the patella, because it's gonna give you the easiest tendon. I mean, I'm doing it with my own hands, and sometimes, honestly, with just your fingers, you can elicit hyperreflexia, very easy. If you cannot get patellar stuff because there is like, I don't know, instrumentation, you know, knee replacement, something weird going on, then you can, patellar reflex L4, they're looking at the quads, right? So you can actually hit the quads themselves to look if there's any contraction there.
Okay.
So another way of checking for L4 is just hitting here, not just here.
Okay. All right, now try on your knees.
Sure.
Okay. I saw them jump.
So if she
Yeah, her
was sitting in a
finger
high
on the
chair,
ground.
Yeah, I was gonna say, normally I'm on the table.
Okay,
and-
yeah, there'd be a
and my
little
legs are
more.
dangling a little bit, yeah.
so what do you do now, if that's the
Oh.
case? If you can't get anything? You can actually just tell her to relax, so just dangle your feet like that and relax like it's a loose spaghetti. And you can actually hold with one of your hands and just do it that way, and it will give you the exact same response.
Okay.
But you just make them kind of relax the rest of it.
Yes,
Try on
I
this
can
leg.
move your chairs and-
I'm just gonna lift your leg up, just kind of dangle it right here.
There you
Maybe
go.
There you
not
go.
good. Thank you.
Beautiful.
Okay.
And Achilles,
What was the? Right here.
Let's just have people cross their legs and I do.
Is that what?
you can
Could
do
we
that.
ask her to cross her leg?
What helps is that so Achilles reflex, S1, makes your foot, this is getting really anatomy, and it's not my favorite subject either, but it makes your foot go down, right? So it makes you plantar flex. So, if you're gonna look at plantar flexion, your foot should not be plantar flexed at baseline.
Okay.
You should dorsiflex it, hit it and see if it's plantar flexed.
So,
Does
I'm
it
like-
make
I'm
sense?
holding
So
it.
you can hold it and then hit it, yep. That's gonna give you a better, like, sense of what it actually is.
Just, take this leg and cross it over this leg for me. Okay.
Push that toe up.
Push the toe
Yeah,
up.
that's,
Up.
Got
Okay.
it?
You feel her tapping into your hand?
I see it.
Hold the hammer a little bit better, like you mean it, there you go.
I'm just scared, I don't wanna do too hard, is what I'm.
You're not,
Okay.
it's not happening.
Did you feel it with your hand? That it's
I
like
felt it
pushing
that
down?
last one, I did feel it.
Okay.
I think I may have been too low.
Another way of checking it is actually if you hit the bottom of the foot, yeah,
I like that better.
cause it,
I think,
Where on the bottom of the foot?
yes, please.
and there is extinction by the
No,
way,
they're
if you
fine.
try to reflex
Okay.
too much, it goes away.
So look, you relax, you relax.
Okay, okay.
So I'm gonna push, look. You see how, like, just tapping down with my hand?
Okay.
Because all we're doing is stretching the tendon, right? So any manner of stretching the tendon does the
You
thing.
can try the other
I'm
foot,
putting
cause I think
tension
you
on
may
her,
have
but
tried
she's
it.
relaxed.
Mhm.
Okay.
There you go, you got
See
it.
that?
Yeah, okay.
No, reflexes do
That was
extinguish.
actually better
Yep.
than the other one.
It was good,
Uh-huh.
okay.
Yeah, it's the easy
Learning
way.
this right now.
Yeah.
May I try the other foot, same? Let's do it. Okay, so relax your foot, I'm gonna put some tension over here.
Awesome.
Okay.
Got it. So they're symmetric to you? What do you think?
I think so,
Okay.
honestly.
They look symmetric to me.
It seems so.
You're completely fine. So is this hyporeflexic, hyperreflexic, or is it normal?
I don't, like, honestly, I don't think I would have enough knowledge to say, you know, I
That's-
haven't seen enough hyper or hypo to say.
That's fine. So these are pretty nice, normal brisk reflexes. I would give it a 2+.
Okay.
I myself have 3+ reflexes, and you know that somebody has a hyperreflexia if it's spreading from one side to another side.
Okay.
And that's not truly pathologic, that doesn't mean you have a disease or anything like that, it's just that you have hyperreflexia. What is pathologic that we did not check, that we definitely should in a seizure patient, is clonus and Bobinsky. So, do you guys
Is that
remember?
when you rub the bottom of the foot, see if the toes curl in, or no?
That's a normal response, so
Oh,
if you
okay.
flex your toe, it's normal, but if you flail it up
Okay.
like a baby, that's not a promotor neuron problem. And in a seizure patient, it's important if there's an intracranial lesion. And that's pathologic, but let's go back to the reflex grading again. So it's 0 to 4, 0 no reflex. reflexes, 1 hyporeflexia, 2 right in the middle, normal, 3 hyperreflexia. I hit here and my hands are flexing a little bit. Now what do you call 4? If I'm hitting here, I'm flexing, that's 3. What would a 4 be?
You hold it there?
It's actually clonus. If you start going like this, if you have clonus, that's the time you call it a 4+.
Is that always pathologic or some
It's
people
all,
just?
clonus is always pathologic. So, you can see clonus in regular reflexes, but the best way to check clonus that's really obvious is again, dorsiflex the ankle and see if there's any beats. So it's very difficult to mimic or fake, so
Okay.
when you dorsiflex the foot and the foot keeps beating on your hand, it literally goes like this.
It's like
We'll
asterisk.
find
It's
out
not
for you in the
really
hospital.
good.
one
It's
day.
not really asterisk, but
Okay.
yes, you're right, it is a continuous
That's what you're looking
muscle
for.
jerk that keeps going on, that's 4+, that's
Okay.
very concerning, especially if it's unilateral. It localizes to the central nervous system. So I would never skip Babinski or clonus,
Okay.
so.
Clonus is checking your
Clonus is the-
dorsiflexing,
Yes,
and then just by doing that, the patient will,
yes, so you dorsiflex and you hold it there, and they will just keep going like,
okay.
very hard to fake, like you just keep going like this.
And
The
to check
patient keeps going.
Babinski, you like rub the sole of the foot?
S1 dermatome.
Okay. May I check this on you?
Sure.
Okay. All right, so, what you call it, what was the reflex where you,
That's the clonus.
dorsiflex, the clonus? All right, so I'm going to just, dorsiflex foot.
Gotta be a little faster than
Faster,
that.
looks like-
Yep. And stay there, there you go, and it's not beating,
Okay. That's a lot. All right, now she's relaxing her foot though during this time?
correct.
Oh,
She needs to be relaxed the entire time we're checking reflexes.
May I have your left foot here? All right, so just relax the foot, gonna pull your toes to you. Try it again.
Perfect. No clonus.
All right, cool. Okay, so take the shoes off to check.
Shoes and socks off for women.
May I take the right shoe off?
Apologize for food.
No, you're good. Okay, may I have your right foot? All right, so I'll just,
So if you want, you can use your thumb, which is fine. I sometimes use just like the, not really sharp part, but behind that, you're gonna see in your reflex
Is-
number, do you see there's a pointy part? Okay, so you
Is
tell the
it
patient.
a certain spot, I mean, exactly?
Babinski by definition S1. I don't wanna really go into too much weeds. There are so many ways to check for that same reflex. This one is called Babinski, it's the most famous guy. But you're gonna go to the S1 dermatome, we're gonna tell her, this is gonna tickle a little bit, I'm sorry, you
Okay.
look somewhere else. This is the S1 dermatome, but you're holding the foot, so it's not
Okay.
holding, there you go. So it's not flailing up, it's not quite, well, it's kinda going down a little bit. And if you can't get any responses from here, there are other ways of doing it. You can pinch the little toe or induce some kind of noxious stimulus. Anything that's painful over here, if you see that the toe is going up, not really the patient trying to get away from you, but the toe is flailing up, that is an upper motor neuron lesion sign.
Okay.
So she doesn't have that.
Okay. We appreciate that.
And then you would wanna make sure it's symmetrical on both sides.
I'll check those.
So outer sole.
I saw a quick move, I saw.
That's fine, yeah.
Very good.
As long as the toe is not going up, you're good.
Oh, yeah.
Yeah.
Right,
Stand
thank
down.
you.
Alright.
Thank you.
Right.
I promise this looked like it was a lot, but it's just, it really is very quick once you guys do it like full one time.
Right.
And then, what else is left?
Sensory.
Okay? What would you like to use here?
I don't wanna like stab her.
Okay, what do you want to do
Stab.
this? So do you guys remember your spinal cord pathways? I'm sorry, I keep going. So, do you remember your anterior commissure? Pain and?
I know where it is, but
Pain and temperature, so if you don't wanna stick someone, you don't have to, you can actually just go with the temperature. So, come here for a little bit, do you think this is cold? It's like metal, it's cold, right? So, you wanna use it on her and see if it's cold on both sides?
I was like, I was very confused, I was like, this is for hearing, but now I see where you're going with that, okay.
Every dermatome? Is
No,
that-
you don't, absolutely
Okay.
not, unless they come in with a specific complaint about that dermatome, you don't.
Okay.
So would you just do like, just the hands, or you also do the ankles?
for her, because this is a seizure complaint, I would just do hands, ankles, and you're done.
Okay.
Just compare side to side.
But I also need to do like do you feel the same on each side, or you just do temperature?
You can do both you can do both.
Okay.
Temperature is definitely more specific than touch, so.
Oh, okay. So, Ms. Smith, we're almost done parking in front of you. So, can you just tell me how this feels? Okay? So, do you feel equal on both sides? How about this? Do you have it in your arms? Okay, perfect. Ankles? Still cool? Keep them in your leg. Okay, thank you.
That's a very easy test. So you got pain, temperature, checked, and you also got touch, vibration, proprioception. That's another part. Yeah, you did the touch, but if you really wanted to get proprioception, this is not the lever in it, this is the vibration. So that's the one you can go, you feel this and the same on both sides.
Okay.
So if you guys wanna practice that, you could do that too.
You want me to do it? Okay.
Alright,
But do it fast so it doesn't extinguish.
okay. Now you hold it by just this part here?
Yeah, if you hold it from here, it's not gonna
Right.
vibrate.
How do you like tap it on yourself, or does it really matter?
Yeah.
Okay.
You tap it on yourself.
I'm gonna just, check to see if you feel the vibration system up down your arm, up in your legs. Feel that?
Try to go to the joint and not the bone
Okay.
or tissue.
I feel it getting weaker.
Yeah, so
Okay,
one
so-
time, very fast on each side,
Okay.
should cover it. But yeah, you can just hit it faster and, yeah.
Right.
And then the same thing with the legs.
So feel this is vibrating a little bit more.
Mhm.
Okay. Okay, good. All right, so like, would you do the hip and the knee and the ankle?
I wouldn't go to the head. Mostly common things coming, if anything's gonna go away from neuropathy, it will be a diabetic neuropathy on the toes. So knees and toes should cover it.
I have a quick question. So for the, going back to the Babinski,
Oh, yeah, I imagine like, this probably
we
absorbs.
learned that Babinski was normal in babies. At what age does it not become normal?
6 months. So it's about myelination, right? So if you myelinate your nervous system, your reflexes start acting normally. So
Okay.
about 6 months or so, you're supposed to start seeing
Okay.
Babinski.
Thank you.
Yep.
By the way, remember on pain sensitivity, I just noticed this because the resident who was working last week pointed out, be careful, the cold sensitivity only works if you're keeping the tuning fork out of your pocket.
Correct.
If it's in your pocket, it's not gonna work. You're gonna need to grab something else.
Especially if if the specific complaint, so right now we're doing a pretty glue exam, right? But if the specific complaint is numbness or tingling, your specific complaint is completely sensory, then you have to do every single modality. Then you have to do everything. For our patient, it's seizures, so we're really trying to do, is it upper motor neuron? Is it lower motor neuron? Is it symmetric? That's all I'm trying to answer right now. So, before we move on, can I really just, this is a very quick and easy point to make. Seizures, let's say that you have a brain pathology, do you expect hyper or hyporeflexia? Hyper, correct, everything's gonna go down. Do you expect yes Babinski or no Babinski if there's any seizures or brain stuff?
Yes.
You don't have to have it, but if you do have Babinski, that means there's something in the upper motor neuron. Clonus means hyperreflexia, we covered that too. And I think that's it for the exam, for the reflexes. There is one thing that if you don't have, in real life when you're a resident and you cannot examine a patient very thoroughly in the emergency room and you have a lot of cold strokes pending, there's one thing you can do. If they can get up and walk, that's gonna give you pretty much everything. So always look at the gait. If there's a normal gait, you know that grossly motor and sensory is usually fine.
So,
You can look at the gait now. What's it?
I forgot to answer the words, to repeat the words next to me.
That's
Yeah.
okay.
Mrs. Swift, would you get up and kind of walk to that table and walk back to us?
Sure.
Thank you, Ms. Van. It looked kind of fine gauge.
It looks like a normal gait. If you wanna go a little bit more in detail and you don't have any time, you can also tell them, can you walk all the way down there, and when you're coming back, can you come back on your tiptoes? If you can't do this, your plantar flexion is 5 out of 5. And if you can't do this, your dorsiflexion is 5 out of 5. So walk on your tiptoes, walk on your heels, and then the tandem gait. That covers everything in about 5 seconds.
Okay. So if they can do the tandem gait, then their cerebellum is probably fine.
And the proprioception is also fine.
Proprioception is fine.
Yep. So you cover both of things. So there's some tricks that you can do without really.
So if you were to
tension.
do that, like, you would still need to do the cranial nerve exam, like what parts of the exam would that cover, like all the,
For cerebellum or for what?
like you were saying that that's the quick way to do it?
Yeah.
So what would you still do if you were doing, like, you would do cranial nerves, would you do like?
Cranial nerves, I feel like, are the least,
Seizure related?
yeah,
Mhm.
unless you have something really big in your brain that's causing, like, let's say facial nerve
Mhm.
enrollment or something like that. And you can't see that when you're just looking at her and speaking to her. You don't have to go one by one. So if I were to pick some things to do, I would just do mental status. I'd probably just do gait, and that pretty much gives you, and reflexes, never skip them, but mental status, gait, reflexes. In real life, we do
Everything.
all the things, and it takes us about 2 minutes.
But that's how you get good at doing neuro exams, doing a lot of neuro.
Right, yeah.
Also, by the way, and this is just, mentioned this last week to the group, your students, you can cheat. That is to say, you can have a card or a sheet of paper that walks you through the things that you need to test. You don't have to have it memorized yet. And so, for example, on when you get into the psychiatry side of things, the mental status exam is like this, you know. So I have a sheet that's, actually, I believe it's posted on Canvas, where literally it goes down through 20 or more items that you need to check. Put it on a clipboard, put it on your, tablet, whatever, and just go down the list, you know. I mean, try to maintain eye contact with the patient as much as possible, but, it's okay to look down and say, oh, I didn't ask that question, you know. So when you're training, don't feel that you need to know how to flawlessly do the whole thing. That's why you're in training.
You can go back and forth always,
Yeah.
right? Like, if you forget something, you can go back and check it again.
Yeah.
Or some other part of the exam will be different too, so you can be a little bit messy, it's completely fine.
Also, in terms of the recall of the words, there are lots of different ways to deal with it. You can, say, here are 3 words, always make sure they repeat the words to you back once, just so that you know they heard you correctly. And then, if this is something where you're at the end of the exam and you forgot it, forgot to ask them this, make small talk for a minute or 2, and then come back to it. That's fine. Anything that gives that interval will work. You just want a distractor interval in there. That's it. So, normally we do it as other parts of the exam, but it doesn't have to be. So,
I have another one, sorry. You mentioned that the hyperreflexia, possible Babinski's, and then the clonus will be present in seizure patients.
Sometimes.
Okay, and then, but when you control them on medication, do you still notice that as a physical exam, or is it gone now?
So let me backtrack a little bit. In a seizure patient, if there is a brain lesion, then you might see hyperreflexia or clonus or Babinski. Most seizure patients, their exams are gonna be stone cold normal, because most of them have a tiny little nerve that is affected in the mesial temporal lobe. It's not gonna give you any motor, sensory, or reflex abnormalities at all. It's just that if you see them, if you see anything that's abnormal or asymmetric, there is an upper motor neuron lesion, that just puts like another red flag in their file that they may have a lesion in their brain. That's all. But if they don't have it, that doesn't mean they don't have seizures.
And also sometimes immediately after a seizure, they'll have.
They will be hyperreflexive,
Okay.
just because their their brain was on fire for a little bit.
Does it change how you would treat them?
About the,
Like if they have a lesion versus not having a lesion?
so you definitely,
Like,
it
would you take it out, or how would that work?
Would
Somebody, would you call somebody else to take it out?
So you would probably have to figure out what is it, number one. So did they have a small stroke? Did they have a small bleed? Was it a congenital thing? In one of the slides that we saw earlier today, there was a cortical dysplasia that happens at birth when you are developing a uterus, but usually it's completely fine until you have a seizure, and then it becomes a problem. So depending on what it is, right? So it will change your workup plans. You will definitely get an MRI brain with and without contrast for a seizure patient anyways, but if you think that this patient has stroke risk factors, you might go ahead and, also get the vessels, for example. But that doesn't necessarily mean your treatment is gonna change. If they're having seizures, you're treat the seizures, that's it. Yep.
Okay. I think you
Thank you so much.
I have a couple of observations as an SP, because I get this all the time. So normally, you'll get a birthday on the door, but y'all forgot to ask the age of
Well,
the person.
My thought with behind that was, if we're in clinic, we're gonna know your age, and
Right.
you're just coming into us, we're gonna know your age from what you wrote on the form.
Right, that's.
So if you didn't know your
Right.
age, would it work? Like, would that count as a mental status exam?
Here's the thing, it's a great point, because do you guys still have step 2 CS?
No.
No, CS is gone. My class is
So
the
it
last
was a
one.
checkpoint, right?
It was,
So
okay.
if somebody's evaluating you, they will go through that checkpoint. So you gotta ask age,
So
gender.
you didn't realize, okay. I considered that, but then I was like, I only know her age because of what she told me on her intake forms.
Yeah.
And remember, there's a difference between sex assigned at birth and gender. So you always want to ask both questions.
Okay.
What was your sex assigned at birth? What is your gender? Okay, or what gender do you identify as? Okay, it's just a standard, one of those little things that the psychiatry department is responsible for complicating everybody's lives by putting that in EPIC. But it's important because, one of my younger son's best friends is a trans man. It's important because he's only had top surgery, okay? So he's still got the organs that were assigned to him at birth, So you can't ignore that, but you also want to identify him as he identifies.
What other feedback did you have?
This happens all the time, and I think it happened here today, but, so when they're asking the history, so many students will take what the diagnosis is or the complaint is, let's say I have a headache or a seizure, and they'll say, so do you have any seizures in your family? The seizures run in your family, the headaches run in your family, and they take that as the family history, and they forget to get the true family history. So they'll write that down, that there's no history of seizures in the family, but then they don't go back and say, well, tell me about your family history, tell me about your mom, tell me about your dad. So there's other things, but a lot of times students will take that as the family history and move on, and not give the full family history. That happens all the time. And there could be, there really wasn't anything today, but there could be a lot of things there. And kind of like what he said, make it a conversation. I know it's hard with the three of you, but the more you can make it a conversation and try to make a connection, the more the patient is gonna give you feedback and not just question, answer. Just kind of, wow, I'm sorry to hear that, I'm sure that really scares you, and just make a conversation. I know it was really hard today, but that's always gonna be really good. That's it.
Thank you.
Thank you.
All right.
Quick question, we talked about sex versus gender.
Mm-hmm.
So is it appropriate to ask a patient, are you a male or female?
No, because if you're a trans man or a trans woman, you identify as male female, okay? So that's why you use the phrase sex assigned at birth. And the only reason you use sex assigned at birth is most people don't know, haven't had a full karyotype done. So they don't know whether they've got 2X or an X and a Y, but they know what sex they were assigned at birth. And gender is how you identify, okay? And again, that becomes important. My son's friend identifies as male. And in his case, he has had the top surgery that allows him to physically look male. But, you also have to remember most trans people do not actually do a lot of reassignment surgery. They will typically only go through what they absolutely feel they need to. So, does that answer the question?
Yes.
Cool. Yes. Yeah. Yeah, you're gonna have to do the next the next three, we'll have to do a quicker version, and that's okay.
Oh,
We've gotten a lot of good stuff out of the
First one's
yeah, the
Nicole
first,
Maurice.
yeah, so.
Thank you
don't
guys.
want just
Um,
I'm just
yeah,
worried about time.
yeah, given the time, yeah, would it be okay if you two handle the exam of the next standardized patient as a demo?
Sure.
Okay, let's do that for time's sake, okay?
So do we get her diagnosis?
Yeah, I had a question about
Yeah.
that as well. Like, after you've done like a history and a review of systems, you're moving into that physical exam, and you have a pretty high suspicion this sounds like focal seizure to me. Do you head into that physical with like a list of differentials, like maybe this is a tumor, is it malignancy, is it, and like, as you're moving through the exam, are there certain things you're able to cross off that you're
Yes.
looking at?
Absolutely, and that's the point of the physical exam too. If the exam looks, again, if the exam looks stone cold normal, then it's likely that this may be a focal idiopathic partial seizure as opposed to something big causing it. And if your exam is very abnormal, there's facial droop, there's super bad weakness, then you know that there's something in the brain on the left side that you have to get an MRI for.
Yeah, so like, we have seizure, we're gonna see if this is some kind of lesion, or if it's the idiopathic kind, and we're
Correct.
gonna move through the exam with that in mind. Okay.
Yep, that's always at the back of our heads, differential.
And I know we spent some time on like infection, would there be something, we talked about possibly syphilis, when we were going through the history, would there be like something that you could,
The most
Test.
common things for seizures are usually in elderly or in adults, it's going to be stroke. That's the most common thing, and then you always wanna make sure cancer history, because you don't wanna miss a metastatic lesion. And then in very elderly, dementia is a big risk factor, because your brain sclerosis, and when it atrophies, it forms scar tissues pretty much, so you always wanna make sure that they don't have dementia either. So those are the big things that you gotta be aware of. All right.
Go for it.
Okay, I'll do it. Hi. I'm Dr. Cawthorn. Nice to meet you. What name do you go by? Marley Stormy. Nice to meet you, Marley. I'm gonna go through some basic demographic things. Can you tell me how old you are?
30.
Awesome. What gender were you assigned at birth? And what do you identify as? Okay. What do you do with your time?
Well, I'm a bus driver.
Bus driver? Okay, for how many years?
A lot.
Great. Are you in a family?
No, I'm in a long-term relationship, but I'm still single.
Do you drink alcohol?
Okay.
Okay. Do you use any kind of tobacco? Okay. Any kind of other drug? Let's talk about why you're coming in today. What's bothering you?
I'm concerned about an episode that I had at work a couple weeks ago.
Okay. Is this something that's kind of recurring over and over again, or something that's only happened once?
Well, this is the first time this has happened.
Mhm.
Since I was 16, I've kind of had my arms jerk sometimes in the morning. But the other day at work, my arms were jerking a little bit, and then I fell out, and told by I'll be unconscious after that. And then a coworker told me that for 2 minutes I was, I guess, having seizure, jerking my arms, coming in, you know, my whole body moving. And then I was out for about 30 minutes. And, I remember kind of waking up and somebody took me home.
Goodness, that sounds really scary.
Yeah.
So, ever since you were 16, you've had jerking of your
Mhm.
arms. Can you show me
Yeah,
kind of what
just
that looks
kinda-
like? Like
yeah.
a little flinch?
Yeah.
Okay.
Just, I haven't thought much about it.
So that tends to happen on a daily basis, weekly basis?
Kind of not specific. It's usually more in the morning
Mhm.
when they happen. But,
Does anything make that happen more frequently or trigger it?
it seems when I have less sleep,
Mhm.
or maybe I drink a couple glasses of wine,
Gotcha,
it
okay.
gets a little worse.
And so until, you know, this episode that happened recently at your job, you never lost consciousness during this episode. But then with this one, you lost consciousness?
Mhm.
Okay. And nobody happened to take a video or anything of the episode?
No, like the coworker that was with me told me, you know, kind of what I was doing, so.
Gotcha. At the time of that happening, were you ill in any sort of way?
No, I just kind of had the normal, you know, arm jerks and then.
It
that
kind of
happened. Yeah.
precipitated into
Yeah,
that bigger
yeah,
thing?
so, mhm.
Okay, gotcha. So you mentioned you're a bus driver.
Mhm.
There's something I want to talk about, just because we have the opportunity. When people have something that sounds like a seizure, and that's kind of the impression I'm getting from the event you just told me where you lost consciousness and you shook. It's really important that they don't drive, because if you were to lose awareness, for example, while you were driving a bus, and get into a car accident, you could really hurt yourself or someone else.
They said I need to be cleared by a doctor before I drive again, so I haven't.
Gotcha. Here in Mississippi, we want people to stay away from driving or doing anything that could hurt them when they lose awareness. So like tub bathing or swimming by yourself, standing over a hot stove or climbing ladders, getting on a roof,
Mhm.
things like that. But the law for driving is that you have to go at least 6 months without one of those episodes. So, family history wise, did your parents have any medical illnesses?
No, they don't really still,
Gotcha. Do you have siblings?
I have a brother and he has seizures.
Okay. When was he diagnosed with seizures? Gotcha. Does he take seizure medication?
I'm not sure.
Gotcha. Do you take any kind of medication?
I was on Depakote for a little while, but I
Mhm.
was kind of bad about taking it, so I haven't taken it for a while.
Gotcha. What were you taking Depakote for?
I guess it's for seizures,
Okay.
or not seizures, but the arm jerks, I'm not sure.
Did it help?
Didn't specify. I don't know, I wasn't very consistent about taking it.
Gotcha. Did it cause a side effect or anything that made you not want to take the medication?
No.
Just forgot?
Yeah, for me.
Deal. Okay. Back to family stuff.
Mhm.
Do you have kids?
Mm.
Any other medical diagnoses that you have? A thing that we always talk with for women, are you still menstruating?
Mhm.
Okay. Do you use any kind of contraception?
Mhm.
So people who have epilepsy have a slightly higher risk of having birth defects in their kids, but a lot of our anti-seizure medications can cause birth defects. So obviously, we're gonna talk about an anti-seizure medication today. I'm gonna try and choose one that will be able to help your problem and have a lower risk, but things like using contraception can be helpful. How many sexual partners do you have?
Just one.
Just one, male, female, male. Do you use any kind of contraception?
Usually not.
Yeah. Have you ever been tested for STDs? Okay, that's something that we can get into. Is there anything?
Hmm?
I think we're all set. Yep, that was a really good one.
All right. Well, just general review of system stuff. Have you had any issue with headaches, seizures before this episode? Okay. Any kind of stroke history? Gotcha. Any kind of head injury? Deal. Any chest pain? Any shortness of breath? Difficulty vomiting, swallowing, rashes, fevers, night sweats, any kind of sick symptoms that you can think of. Any recent travel outside of the country. All right, I'm gonna do an exam.
We asked about head trauma, right?
Yeah, we asked about head trauma.
Yes.
Okay.
Okay, I know my thing. Can you tell me where we are? Fabulous, what state is this? What city?
Jackson.
Jackson. Deal. What year is it?
2023.
Month?
November.
Date? Day of the week?
Monday.
All right, I'm gonna give you 3 words, and I want you to remember them. I'll ask kind of at the end of our exam. Apple,
Apple.
table,
Table.
run.
Run.
So first, I want you to look right at me, cover one eye, please. See right here. Oh, look right here. I'm checking the outside vision, so I want you to look at me.
Okay.
How many fingers?
Mhm.
Perfect. Perfect. Swap eyes. Perfect. I want you to look over my shoulder. I'm gonna shine this light in your eyes. Beautiful. Can you say ah for me? Ah. Perfect. Perfect, perfect. Great. Does that sound about the same on both sides? Fabulous. Follow my finger with your eyes. Here. Here. Down. Over here. And it comes to the center. Beautiful. Close your eyes as tightly as possible. Perfect. You can open them. Smile for me. Beautiful. I'm gonna touch your face. Does that feel about the same on both sides? Awesome. Can you bring shoulders up? Excellent. Can you turn your head to the beautiful? Turn your head that way. I'm gonna push. Don't let me. Excellent. Turn that way. Push. Don't let me. Beautiful. All right. Reach up. Touch my finger with you. Touch your nose. Good. Other side. Perfect.
Alternate.
Let's do that. Good. Show me strong arms. Keep them strong. Beautiful. Beautiful. Arms up. I'm gonna push down. Push me down. Beautiful. And arms out straight. Try and close your arms. Don't let me. Good. Grab my fingers and squeeze tight, tight, tight. Excellent. I want you to lift that knee. Keep it up. Keep it up, 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 up. Good. And this one. Excellent. Can you straighten that leg out? Keep it out there. Okay. Perfect. Straighten that leg out. Beautiful. Now I want you to take that heel, put it here on your ankle, and bring it up to your knee. Perfect. Can I see the other side? Beautiful. Got my tuning fork. Does this feel cold? Does this feel cold? Are they about the same? How about here? And here? Beautiful. Last couple of things. Here comes my silly, scary hammer. You can just relax your arms on your lap, just like that. Perfect. Beautiful. Come around here. Oop. There we go. Right here. Awesome. Now let's sit down. I'm gonna lift your knee a little bit. I want you to just relax. Beautiful. Just relax it. I've got it. Perfect. Can you put your leg across my lap? Perfect. Now push right here. Beautiful. Put that down. Beautiful. Would you mind removing your socks and shoes for me? Excellent. Way up here. Perfect. And then bring this here. Beautiful. Can I see the other side? Awesome. And I'm gonna keep you there and put that down. Beautiful. Can I try the other one? Awesome. Can you walk across the room for me? Come back, one foot in front of the other. Excellent. You can have a seat. All right. I think I've done all my things. All my things.
How many minutes did it take? Just curious.
We started right about noon.
So this person has a brother with,
Forgot to ask her recall.
oh, what are those? What are they telling you? We can leave our exam.
Apple and a couple other things about sugar.
That's fine, we're in front of a bunch of people, that's okay. We're both doing our best, aren't we?
Was one of them wrong?
One of them was run. Huh.
And a sugar know that.
Uh-huh.
Okay.
Fascinating.
Sometimes it's
Fascinating. Apple table run, that's good, we good.
Yeah, remember, this is not really meant as a test of long-term memory.
Uh-huh.
It's basically a kind of short to medium term. So if you go over a certain point, you can kind of expect people are gonna miss a question. By itself, that doesn't necessarily mean anything. But you know, if you were taking into account the time involved, so in her case, you know, wouldn't think anything of it. And especially because she remembered when she thought about it, she remembered the second word. Yeah.
Technically, it's called a 5-minute recall test. I don't think any one of us time ourselves, so
No.
it's usually kind of like.
Yeah, it's,
5 minutes.
yeah, exactly, it's, yeah, within the ballpark. Okay, so what do you think's going on?
So Jenny and
Hmm?
Sounds like a genetic generalized epilepsy to me, for sure. Yeah, because, so we have our family history with our brother having seizures. We have our little myoclonic jerks that are happening in the morning and happening for years, and then she has a whole seizure.
Let me ask you, would you contact her brother?
Would I
Or,
contact her brother?
or ask her to contact her brother about anything?
We probably need some seizure medication. She's not close enough to him to know if he's on
Well,
anything.
she said, I thought you said, did you say he was on something, or did?
She said she didn't
Oh.
know.
Yeah, but I don't know if this is true in neurology, I'll say simply from the psychiatry side. If we had a patient with a relative with a similar disorder, one of the things, and we'd ask is, you know, is your sibling being treated, and if they are, what are they being treated with? Because psychiatric meds are nowhere near as wonderfully specific as neurologic meds, and you get squirrely responses even within a single class of medications. So, for example, the biggest group of antidepressants are the selective serotonin reuptake inhibitors. But the fact that a patient responds to one SSRI does not guarantee that they'll respond to the other dozen SSRIs. Likewise, if they don't respond to one, that doesn't mean they won't respond to others. However, if you've got a family member who responds, that's your go-to. And it's like, we'll start with that one. So,
It's very similar
Oh.
to us too. So if there is a genetic epilepsy, especially if it's a channelopathy, like certain genetic conditions can make your, I don't know, channels, I guess, pathologic, so like sodium channel pathologies. In those cases, there are specific medications that are absolutely contraindicated and other medications that work really well. So same thing applies. They're pretty genetic, pretty familial, and you ask them, they had a horrible reaction to this one medication, but they responded amazing to this other medication that kind of, you know, gives you a diagnosis even.
right. And one other thing I want you to pick up from the examination, notice that when she asked if the patient was sexually active, well, two things. When she said she had a partner, she didn't assume that the partner was the opposite sex, okay? Again, it's just a convention that you want to get into. It helps a chunk of the population feel a lot more accepted, a lot more welcomed into the clinic. And that's really important because the LGBTQI community has been so horribly underserved for ages because of these assumptions. And we're really, really trying hard to break that down. sorry, this is a personal soapbox.
No, it's completely relevant too, so yeah, thank you for bringing it up.
Anyway. Okay, well, thank you so much. All right, folks, so, as I say, feel free, you do not have to submit a write-up, okay? The reason for this is very simple. We have two small departments. There are simply not enough people to grade all 160 some odd write-ups. And frankly, the one time I tried to do it, I realized very quickly that that was stupid on my part. But I will have a question drawn from these two patients, or one question for each patient. So you're gonna wanna make sure you're together on this. In this particular class, I'll just give you a little heads up. We've had such great conversations from the attending and resident that I'm probably gonna wanna relate at least one of my questions to that conversation. Okay? All right, folks. Have a great Thanksgiving. Okay?
Thank you, guys.
Thank you.